Hi, my name is Alice Chang, an endocrinologist at Trillium Health Partners in Mississauga and St. Michael's Hospital in Toronto. And we're here today to talk about insulin use in type 2 diabetes. Well, insulin is one of the many options we have in our toolbox to get blood sugars under control. And the following scenarios are the times when we should be considering insulin in our patients with type 2 diabetes. The most common one is going to be the patient who has maximized their non-insulin therapies, yet their A1C remains above target, which is typically 7%. Another scenario is a patient who's newly diagnosed with type 2 diabetes, yet has an A1C above 8.5% at presentation, then consider going to insulin. Another scenario would be a patient who is metabolically decompensated and is feeling unwell from their hyperglycemia, and especially when weight loss is present. Other patients that you want to think about insulin in are women who are trying to get pregnant or are pregnant because we cannot use our other agents in pregnancy, or in the patient who has end organ failure, either kidney failure, liver failure, or severe heart failure, where again, we cannot use our other therapies. Also the patient with acute illness, let's say some sort of sepsis or pneumonia, or a patient who's on steroid medication. And then my personal favorite, which is really any time you want to think about using insulin, you should, because it is one of our successful options within our toolbox. There are basal insulins, bolus insulins, and premixed insulins. So if we start with the basal insulins, those are background insulins, longer acting insulins that sort of serve as a baseline amount of insulin. There are bolus insulins, which are meant for boluses of food, in other words, mealtime, so short acting insulins. And then there are premixed insulins, which are mixtures of the above, so a combination of short acting and longer acting insulins. There's basal alone, there's basal bolus, and there's premixed. So let's start off with basal alone. Basal alone regimen involves just taking basal insulin, typically given at bedtime in order to control the morning sugar for patients. Now, you can see how basal alone has the benefit of simplicity and convenience because it's one injection per night. However, it does not target therapy during the day. The other option is basal bolus insulin regimen. Now with basal bolus, you have both basal and bolus insulin. Therefore, basal typically given at bedtime for overnight coverage, and bolus insulin given either at 1 meal, 2 meals, or 3 meals in order to target their postprandial sugars. The advantage there is flexibility for the patient in terms of timing of the meals as well as quantity, but the disadvantage is it requires more work with more injections and really more testing in order to do it well. The premixed regimen is simple in that it's twice a day premixed. The disadvantage, though, is that there's loss of flexibility for the patient in that they must eat on time every day and do roughly the same thing every day, or else risk hypoglycemia with a premixed regimen. Part of the negotiation of getting someone started on insulin is offering to stop some of their other non-insulin therapies. Metformin, however, is one of those non-insulin therapies that I would suggest you continue when insulin is used because it works synergistically with insulin, allowing the patient to use a slightly smaller dose and therefore allow it to work better. However, some of the other drugs may be stopped. So sulfonylureas or insulin secretagogues can be discontinued if the patient is on more than just basal insulin. DPP-4 inhibitors, GLP-1 receptor agonists, SGLT2 inhibitors can be combined with insulin therapy. However, again, as part of the negotiation, may end up being discontinued. TZDs and acarbose are generally stopped when insulin is started, TZD because of increased side effects, and acarbose because of the number of pills required. Whatever dose you pick to start is not going to work, and that's completely okay, because the most important principle is that titration is the key to successful insulin use. So if you're not going to titrate, I would suggest not starting. The usual thing that people start with is basal alone, and if you choose to do that, then we ask patients to start with 10 units at bedtime and ask them to titrate by 1 unit every night until their fasting blood sugar is at target. For the other regimens, I'll provide for you a resource you can go to look at other formulas that people use But again, starting dose is not the most important part. Pick a number and start. The real key is the titration. The guidelines website from the Canadian Diabetes Association, which can be found at guidelines.diabetes.ca, has a number of resources for both healthcare providers and patients. And one of the resources for us is the insulin prescription tool. That particular tool allows all of the insulins to be on one sheet of paper and serves as a functional prescription. But the best part of the tool is actually the backside of the tool that gives you instructions on how to initiate and titrate the various insulin regimens that we've talked about today. Thank you very much for watching this video. I'm Dr. Alice Cheng on behalf of the Medical Post.